On this special episode of the ASC Podcast with John Goehle, we attend the May 2021 New Jersey ASC Association's virtual conference and visit with Jeffrey Shanton to discuss New Jersey ASC issues and host a roundtable discussion with speakers at the conference.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. This episode is sponsored by Ambulatory Healthcare Strategies. The ASC regulatory environment is increasingly challenging, but organizations that outsource their regulatory oversight to Ambulatory Healthcare Strategies have an edge. HS works with ASCs to oversee their quality improvement program, run their meetings, develop educational programs, and always be prepared for surveys. For more information or to schedule a consultation, visit our website at ah-strategies.com, email us at info@ah-strategies.com, or call John Goehle directly at 585-594-1167.
Welcome to episode 132 of the ASC Podcast with John Goehle for June 3rd, 2021, recording from our studios in Spencerport, New York. This is Susan Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies and recognized as one of the nation's leading experts in the ambulatory surgery industry. Mr. Goehle is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory accreditation and finance issues.
So this is very exciting. It's our first actual virtual conference podcast that we've done since the pandemic here. And we had the honor of attending virtually the Spring New Jersey Association of Ambulatory Surgery Centers conference on May 12th, 2021.
And you were the keynote speaker for that.
I did. I did a presentation. It was a lot of fun. You heard it because you had to put up with me telling you what I was going to talk about. But Reflections on 30 Years in the Trenches. I love the title because it does feel like I was in the trenches. And it seemed to have gone over very well. We're going to talk about that topic in one of our upcoming episodes. But the purpose of this episode is to provide New Jersey Association members, and any center in New Jersey, information about what's going on in the state. And there was a nice roundtable discussion from the speakers there on various topics. So, and then I also did a breakout session on keeping current while keeping sane, tips for keeping up with the rapid changes in the ASC management. Not sure who created these titles. They don't sound like titles I would have created, but
I don't know. Makes it sound pretty interesting.
It was fun. And as you'll hear when we talk to Jeff Shanton here, they do hope to be live soon. So that'll be great. It seems like we're starting to get back to normal finally with these conferences, which I'm really looking forward to.
And they're one of the largest ASC state associations, right? The third largest, I
believe, at this point.
Close,
absolutely. Yep. You know, what was interesting too, Sue, is that it's interesting to see how advanced these virtual conferences are getting. You know, even, of course, you and I have been hosting various virtual conferences for through the ASC Podcast, but some of these state associations in New Jersey is really at the forefront of this, have put together quite complex platforms for doing this. The way they set this up is that there's a webpage that you go to, which is a picture of a hallway, like you would see if you were coming into a conference. And then off of it are, doors to go into the conference. There's the registration desk. There's the hall for all the vendors. Yeah. And you just click on that icon for that, and you go into it. It was very nice. It was a good way to visualize what you were looking at, and it made you kind of feel a little bit like you were there.
Yeah, a bit more intuitive. Well, you always say the ASC industry is very adaptable. So
we are.
I think everybody's done very well with keeping up with this stuff.
So our first interview was with Jeff Shanton and Bonnie LaVoy, and they talk about what's going on in the state and a little bit about the conference also. So let's listen to them. This is John Goehle. I'm with Bonnie LaVoy and Jeff Shanton. We're talking about the conference that just ended. And Bonnie, can you give us a little bit of insight as to how you plan for and the types of events that were scheduled for this conference in May?
Well, this was an interesting adventure for us because it was our first virtual event. So there was a learning curve for me. I'm used to being at the podium and speaking, and it was a little different doing things virtually. So it went well.
It did.
We have a great company. They guided us through everything, any questions we had, and I thought it went really well. From our feedback, also very positive feedback from our members. We had one of our post meeting yesterday. We're just now reviewing the surveys to see what we did well and what we can do better. And, a couple of things came forward, nothing big, but things we'll be looking to improve the next time.
Now, do you think you're going to continue doing virtual conferences? I know you've got a live one coming up, actually a couple coming up, but do you think you're still going to continue doing some virtual conferences at least?
The hope is to be live in the future,
Right.
Depending on what happens. You never know what's going to happen these days, but the hope is to be live because the biggest piece that's missing in virtual, of course, is the networking and
Right.
the friendships formed and sitting at the table and just trading secrets and policies and things like that. That piece is missing. On the other hand, for us, virtual is a little more financially, it's better for us financially because we're not worried about a place and food and things like that. But I like our new company so much. It's We Speak Easy. They're
Right.
so good. I'm hoping that we can incorporate them in the future in other plans that we have.
Well, they had a nice portal that made it look like it was kind of cute because it kind of made it look like you were in the waiting area or the lounge area before going into each of the rooms, and you just clicked on one or the other.
Yeah, it was done well, and I think most of our members appreciated that. It wasn't hard to do.
Yeah. So what do you think was the highlight of the conference? You had the Department of Health come in, talk a little bit about things. You had, a couple great speakers. I was there, of course.
I better say you.
Oh.
I better say you.
But it was fun. I mean, and plus it was a huge audience. I was actually quite impressed. Jeff was telling me before we started recording that your membership is growing dramatically right now, too.
Well, what was interesting is we did something new this year. We did what we call not the rookie track, the novice track, and then the expert track.
Yeah.
So it allowed those people, especially in New Jersey, with a lot of the new one-room centers with new administrators, to sit back and do quicker seminars and learn a little bit more basics than the rest of us. And I put myself in that group who've been around for a long, long time, and we didn't need the basics. We needed to move on to the next one. There were several. I mean, the COVID one, which featured all three hospital systems, was very interesting. Not being involved with the hospital, it was interesting to see how they developed their plans and their processes through that pandemic. Yeah, there was a lot of highlights, and yours is really always brings it back home. Stephanie Mosguy came from Baltimore to talk about Medicare, so we had a lot of featured guests, and I thought it went really well.
Can you give us a sneak preview of what your next conference is going to be, including?
I don't know yet. We just met yesterday, and we're going to take. We really work year round. We have monthly calls. We're going to take off June and July, and then hit it back up in August and start discussing when, where, how, and what kind of speakers we want. And a lot of it will largely be based on the surveys and asking our members what they want. So that's how we'll proceed.
And do we have dates yet for the conferences?
We do not.
Okay.
Not yet.
So I'm sure you'll tell me as soon as you get them so we can tell our listening audience. Bonnie, what we're doing is we're going to have two episodes out of this. One episode is going to be for the state association. It'll be including this interview so that we can, talk a little bit about things that are specific to New Jersey. And then I had the honor of being able to have a panel discussion with quite a number of your speakers, which basically had a national focus. So we'll make a national podcast out of that too, so that everyone else in the country can hear some of the great speakers we had in New Jersey.
I was able to hear that, and I liked what our speakers had to say. I think we had some really phenomenal speakers, very knowledgeable, very dedicated and committed people to the industry, and that made me very happy.
Very good. Well, thanks so much for your time, Bonnie. I appreciate it.
Thank you, John. Thank you, Jeff.
Sure.
See you, Bon.
So I'm here with Jeff Shanton, who's the president of the New Jersey State Association, and what a great conference that was. I was able to join you for most of the time to listen to the other speakers, and I had the honor of being your keynote as well as doing a session. And then at noon, I was able to interview, I can't remember how many people, it was about 4 or 5 of your speakers to talk about kind of issues that are important to everybody in the country. But I wanted to talk about what's going on in New Jersey right now. Jeff, your conference was very popular, and you were telling me before we started recording that your membership is up. So give me a membership update, first of all.
Well, thanks, John. Appreciate it. we've been growing by leaps and bounds. I've been part of the organization for, I don't even want to say, lots and lots and lots of years. Bonnie and I, in fact, we go way, way, way back. And we remember the bad old days when we were lucky if we had 70 or 80 members, a dozen vendors, things like that. Well, it was always hand to mouth. Well, you can't operate an organization like that. You can't. I mean, you need membership, you need dues, you need revenue, all that stuff. So I just started my 6th term and final term as president of the organization. So when I took over, my first goal was increase membership and increase revenue, which we've done. So we are now in between 190 and 200 member centers.
Wow.
By the end of the year, we're just starting our membership drive. We will obviously go over the 200 mark. And I think that'll put us as the 3rd largest state organization after only California and Florida. So it's amazing, the growth. We also, unlike a lot of state organizations, we have vendor and corporate and associate members.
Right.
So not just people that sell widgets, but like RWJ Barnabas, Virtua, SCA, USPI, Atlanticare, people like that are members, corporate members of the organization.
Mm-hmm.
And then we also have, like I said, associate. That's for the little guys, the little consulting companies that have 1 or 2 people. We give them a break as an associate member. They get to do what a regular vendor member would do, but we have them. So we've got like 50 of them right now. I was actually afraid during the dark days of COVID, during our renewals, that we were going to lose vendors, because vendors are visual face-to-face people. But I was very heartened that we had a little bit of a drop-off. But my goodness, this spring, when we started doing our virtual events on our wonderful platform that you had mentioned with Bonnie, between the Infection Control Conference, the January quarterly, the Infection Control Conference, and then the annual, I think we've picked up 8 or 10 brand new vendors. So they're coming back to us.
Yeah.
And now with the relaxation of restrictions by the governor, we're looking forward to our fall October quarterly meeting, going to be face-to-face. So that'll be a very good thing.
Well, and I think that's something unique about New Jersey, too, is that you have more meetings than, I mean, New York is unusual in that it has 2 meetings a year usually. Of course, things are a little bit different right now with the pandemic. And California has one big conference, but it has a number of smaller focus conferences. But it sounds like you have a pretty robust meeting schedule, which is important in a state like yours.
Like I say, we do quarterly membership meetings. So there's 3 right there, and then an annual. So there's 4 right there. Now that's bare bones. We then put on lots of other things. Yeah. Like I was saying, the end of March, we did, in conjunction with Department of Health, the annual Infection Control Conference all day virtually. That was extremely well attended. I think when I was watching the attendees on it, we never were under about 310 viewers on that one. Obviously a reason, because what it did, the department joined us in it. And, here in New Jersey, there's a requirement that you must have an outside infection control person, but you also have to have a dedicated one inside who has to have continuing education. Well, the department said participating in our infection control conference would suffice as continuing education. So you got a lot of people that came on for that, which was good. And they got a certificate they can, put when survey comes in and everything like that. So it was a very successful meeting, but it's not face to face, like Bonnie said. Our vendors, especially, that's what they like, and that's what we like. And in fact, our October one, we will have educational content like we always do in speakers, but we're going to make it more like a welcome back home, kind of meeting. We're going to do a few fun things. We want people to bond and, network and get back together. Because even though we're big, we're just one big family. That's the way I look at it. Gone are the days, though, when I could walk around and I would by sight know the face of every single person. Now I find myself looking at their name tags because it's, I just can't keep up with the amount of people we have. But it's a good thing. It's a good thing when, you don't have to worry about your finances, you know what I mean? And you can, lobby and do all the kinds of things that a state organization really, really needs to do.
Well, I think that's one of the things that's most impressive about your state association is that it really, truly has a very close relationship with your Department of Health, and a good relationship there, and a lot of support. And that was very evident during the conference. And of course, as you said, with the other conferences that you do that focus on things like infection control.
Yep. I mean, I can send an email or pick up the phone and I can get the deputy commissioner or, anybody like that, and they'll respond right away. We've always had it. It's just become it's become closer during the pandemic. Because when the pandemic first started, the department, even before we were proactive. We reached out to all the ASCs in the state because we saw it coming, and we sent them an Excel spreadsheet and said, we want to know PPE, we want to know ventilators and this and that. Well, we had that before it became mandatory by the governor with public health, one of his public health dictums and whatever. So they were very impressed with that. And from that time on, we have worked hand in hand with them on all the executive directives, that tell us what to do and how to do it, from reopening to testing to all that kind of stuff. In fact, I was just talking to the deputy commissioner this morning. She says Friday or Monday. I doubt Friday, but we should have the newest revised ED for ASCs out the beginning of next week. We're operating under one that was from last October. Can you imagine? I mean, there were no vaccines even last October. So there'll be testing changes and all kinds of things like that. In fact, what they did when I said, look, we need it, they said, well, why don't you guys write the revised ED and send it to us? So that's what we did. So that just shows you there, what we're talking about. So
it's not. So you've given some very good reasons for membership, to join as a member of the state association. Do you have a special deal going on right now? Do I understand?
Yeah, we do. We always have a membership drive. We usually started it in July or August after our annual event. Our annual event was early this year. We did an early one in May, the beginning of May. We usually do second week in June. So because of that, I kicked it off the beginning of June. Any center or vendor who has never been a member of the organization, if you join now, during the membership drive, you get the rest of 2021 and all of 2022 for just one price. So if you join now, you're getting 18 months for the price of 12.
That's a great deal. As a matter of fact, I was joking with Jeff beforehand. I didn't realize that my company wasn't a member because I don't handle that part of it. So we jumped on that deal right away, Jeffrey. So I think
it's a great deal. In fact, I tell all the time centers and vendors when they say about joining, because we're January to January, you know what I mean? So if you join me in June, you're going to get a bill in January. That's just how we work. We don't prorate. So I'm all about transparency and what's best for them. So I tell them, wait until we put the membership drive out, then join. That's your best deal.
Well, and again, I want to emphasize the in-person conferences that I've had with you are some of my favorite. Again, I know so many of your people out there, and the people that certainly it's the same crowd of speakers generally that we see. So it's like coming home again. But it is probably one of the most interactive conferences that we have, and definitely a lot of opportunities for networking, which is so important. Jeffrey, we've just come out of some conference boot camps, and for people that are kind of new to the ASC industry, and we continue to emphasize the importance of networking. I don't know of another industry that requires it as much as we do, because we have to work together so closely.
Well, the other part too, Bonnie alluded to it, is, again, me being the 35-year dinosaur in the industry that I am, and I won't include Bonnie in that. We're getting to the end of our tenure. This, especially we see it here in New Jersey. I'm sure it's all over, but there are so many newbies, wet behind the ears people coming into the industry as administrators, DONs, and everything else like that. they need help and they need guidance. And that is ultimately what your state organization is about. That's why for the annual event, I suggested, and people thought, well, it's never going to work. Well, guess what? It worked wonderfully. We had a dual track. We had a novice refresher track, and then we had a expert track. There were more people signed up for the novice refresher track than there were for the expert track. Yeah. So that just tells you that people are just, they're just craving information. What we also do as an organization, by the way, is every Monday, all the members get our electronic newsletter, The News You Need to Know. That goes out every Monday to members only. We also have been sending out since last March, when the pandemic hit, the department came to me and said, would you be the liaison and the point of contact for everything ASCs for your membership? And I said, no. And they go, what? And I said, no, I won't do it for the membership. I'll do it for every ASC, whether they're members or not. Yeah. So that led me to start publishing a COVID e-blast that just had COVID information in it. And that still continues, not at the pace it did, obviously, months ago, but that still continues. So it reaches out to all ASCs in the state of New Jersey, whether you're a member or not. That still means you should be a member because you're missing other things that are in the news to know, regulatory and things like that. But at least we try to provide a service to everybody.
Absolutely. And I get that. And it's an excellent document or excellent weekly update. So it helps me to keep current with what's going on in New Jersey. So I appreciate it.
And ASCA uses it. There's been times ASCA's called and said, hey, can we use your ideas about this or that or whatever? And it's like, sure, go right ahead.
So my new favorite word is pivot, Jeff. So I thought let's now pivot to what's going on in New Jersey. Kind of give us a brief overview for our listeners here about the activities of the state association, just in general, what's going on from a regulatory standpoint in New Jersey.
Well, John, as you and I were talking about earlier, it's unfortunate with the political climate in the country. And that, spills over to this state in particular. Actually, our sister state, New York, as well. I mean, I think we're kind of like joined at the hip with the way our governors are and what they do and everything like that.
And we face a lot of the same challenges in these two states.
Yeah. Well, actually, I think it wasn't in New York, New Jersey, Connecticut, Pennsylvania. I think all the governors joined together in an ad hoc and said, we'll try to do the same thing all the time. Well, the unfortunate thing is our governor didn't do that. I mean, in fact, when CDC came out, 4 weeks ago or whatever, or 3 weeks ago with the masking stuff, he just said, we're not following it. Yeah. We're not following it. And, so obviously you can imagine what my life was like when that came out, because everybody was calling and emailing saying, oh, we don't have, I go, no. Well, CDC said it. I go, does not matter what CDC, CMS, or anybody else says. All that matters is what the governor and your regulatory bodies in the state say. They take precedent. That's why you have to listen to them. Well, he came back and forth with it a couple times and everything, but the upshot is you're still masking in healthcare facilities and things like that. But what's really been an issue here is reopening the state to business and things like that. And right now, as we speak, there's fast track legislation, no public hearing, none of that kind of stuff. So, it's kind of iffy as what's going on here. But the legislature and the governor are trying to make it look as if this law, if it's passed, would back down on his emergency powers. That's a big issue amongst a lot of states.
New York also.
Well, the thing everybody has to realize, which I tell them all the time, is per the state constitution here, this is the second most powerful governor in the country. Okay, so there's no governor in the universe I know that is going to give up his powers.
That's right.
It just doesn't work that way.
Yeah.
So, a lot of legislators, when this was out a week or so ago, said, what is the purpose of this legislation? It really doesn't do anything. Well, there was so much opposition that the Assembly Speaker pulled it. The state president and the Assembly Speaker, they just put it up, fast-tracked it, no committee hearing, no public hearing, none of that. They tweaked it a little bit here and there. Essentially what it would do is he's not going to issue any more public health emergencies. Doesn't mean a thing, because there's caveats in there that say, well, if the rate of transmission, and good luck trying to figure out what that is in this state and the metrics they use, I can then declare, you know what I mean, and go back and do, all kinds of different things. So you're really not accomplishing anything. It also says, well, we're going to take away a month after the bill's passed, the executive orders will go away. Well, they will expire, except for 14. Well, those 14 are the ones that matter.
Yeah.
So, it's like I don't understand what it really does. And the bill that's going through now also says that there is no ability of media, anybody, to use Oprah or any other sunshine laws to try to get data from the governor's office or the department of what transpired past. So there you go.
Yeah.
But what on the bright side, I speaking with the deputy commissioner this morning, we should have a revised ED out for ASCs by the beginning of next week that will finally do a few things, if people were vaccinated. Because right now we have to test and you have to test. And after you're tested, you have to quarantine until you come in and do the procedure. So there's going to be some relief for some of that, probably the vaccinated people.
Right. Similar to what New York has already done. Yeah.
Right. There's going to be some. Yeah. See, the difference was with us, as opposed to New York, we were dealing with a 16-page executive directive.
Yeah.
You know what I mean? That had to be gone through. Literally, we did this line by line, taking in, taking out. And some of the stuff in the directive were dependent upon executive orders from the governor. I know I confuse people when I say that, but it was so intertwined. It's like, well, even though we don't need that in there, well, we can't take it out unless the governor rescinds an executive order. Like right now, we still have to every Monday report via a portal PPE inventory and other kinds of questions.
Yeah.
That ship is, you know what I mean? That ship has sailed.
Too much, right?
There's no reason for any of that, anymore. And I keep telling the department, but the problem is it's linked to an executive order.
Yeah.
So we have to see if we can get that rescinded to get that out of the executive directive.
I want to go back to we had talked earlier about the infection control requirement. And one of the things that's been near and dear to my heart, being on the board of the Ambulatory Surgery Center Certification Board, BASC, which oversees the CASC and the CAPE credentials. New Jersey does not accept the CAPE credential, to the best of my knowledge, as certification for that independent consultant that would come in.
Correct. That's something that's been discussed.
Yeah.
Believe me, that's something that's been discussed. In fact, we have a whole laundry list of things. What we as the organization always did is about 3 times a year, we went down to Trenton and we sat with the department, just us. They told us what they were thinking. We told them what we were thinking. It was a great, can't do that anymore because state offices are still closed.
Yeah.
So we're hoping that come July, August, when the governor says he's going to reopen, that we can then sit down and have a face-to-face with them and, talk to them about, some of these issues.
Well, I mean, it's critical, I think. I mean, so many of, CAPE is growing leaps and bounds right now. It's becoming a very popular, and of course, it's focused specifically on ASCs. There's nothing wrong with the CIC credential. It's just it has a completely different focus than ours.
Well, as I say, the state moves slowly. The departments move slowly. People have to understand that all the time. Like the ASC regulations, I mean, there's been talk about reviewing them, revising them for years and years and years. And I remember, God, it has to be a dozen years ago or so, maybe even more, when we were actually engaged with that. And it never went anywhere because the Department of Health was locked up on the definition of what is surgery. So there you go.
Yeah.
There you go.
Any other legislation or issues on the horizon that New Jersey surgery centers need to know about?
Well, we've been pretty lucky. It's an election year, so that helps. Yeah. all the Assembly, Senate, and the governor are up, so that helps.
Yeah.
But every year we usually have a fight with, the ambulatory assessment that we always have to beat back, which we've been successful in doing forever. That didn't rear its ugly head this year because of the election. I'm sure it's going to come up next year.
Yeah.
It always does. We're always very, very careful about that. The only other thing that we're watching that goes into effect July 1st, I believe, is the healthcare transparency law. Now, that's not out of network or disclosure. This is a law that will mandate, not just in ASCs, but hospitals and everything, that doctors are now going to have to make sure that they either embroidered or with a badge, their exact and full name, what they are, their credentials, everything like that. And in an ASC setting, we're going to have signage that lists all the doctors, anesthesiologists, everything like that, whatever available for the public to see. That goes back to, the impetus of that goes back to, several months ago when, we were in COVID, and I don't know exactly what law, bill, or whatever was being testified, but apparently some people presented themselves to the governor as doctors that weren't. He found that out, and what hit the fan.
Yeah.
And all of a sudden, this bill that had been sitting there and languishing for 8 years now got fast tracked and pushed out. So
yeah.
That's what we have to do. The other thing is we're still our out-of-network legislation, our surprise billing, which we had before lots of states did. And as an organization, that was going on for, God, I probably fought that for 8 years, not on the premise of what it is, but just on how the bill was written.
Right.
It just was no good. I mean, for instance, it would have made it a felony for doctors to, you can't have felonies for doctors.
Over the top,
things,
yeah.
And stuff like that. Well, we finally got one that, was okay. And that included what the feds are now looking at, baseball arbitration, for emergency room docs and things like that. If you go to a hospital and your hospital's in network, but your anesthesiologist or pathologist or whatever isn't, those are the protections. And instead of, them just saying, well, sorry, doc, you have to take what the in-network rate would be. Now those docs can baseball arbitrate. So that's a good thing, because I know our congressional delegation used our state law at Washington to say, hey, why don't you do something like this?
Yeah.
Once again, what everybody has to remember with this is another state versus federal thing that, we have that state law already. So it really doesn't much matter what the feds do.
Yeah.
With their law, ours is there in place and applies. Yeah.
Well, Jeff, as always, it's a pleasure talking to you. I'm looking forward to, now that I'm a member, I'm looking forward to even more communication. And keep in touch. We'll definitely be at your big conferences here and record another episode. And you always have great speakers that have a national pull anyway. So it's always a great opportunity for us to get some content for our conference. So I appreciate that from your organization.
Thank you, John. You're always welcome. You always will be. And thank you very much for the kind words. And we'll see you in October.
Sounds good. Thanks so much, Jeff.
Sure. Have a good day.
Thanks. Thank you for being a loyal listener of the ASC Podcast with John Goehle. But did you know that you can enhance your experience and support the free podcast by becoming a patron member? Patron members have access to ASC Central and add-on service at a very reasonable price. Patron members have access to our regular drop-in virtual meetings where you can discuss issues that you are dealing with in your ambulatory surgery center with the hosts and other members. Members also have access to valuable member resources, including a document library with a growing list of resources, including the rules and regulations, guides to maintaining compliance, example policies and procedures, infection control resources, example risk assessments, example committee and governing body minutes, and over 60 disaster drill scenario kits and example forms and checklists. Members also have access to some of the virtual conferences that we have presented, including the Provider Credentialing Conference, which we offered in December 2020. It's a New World Conference in 2020. Infection Control in-Service to meet the challenges of COVID-19, and the ASC Mandatory Education Program, which is a valuable resource for annual education for your staff. Membership helps to defray the cost of producing the podcast, including the research staff, travel costs to conferences, equipment costs, and production costs. For more information, you may visit ascpodcast.com. To become a member, visit ascpodcast.com. And then next, I had an opportunity at noon on May 12th to do a panel discussion with quite a number of the speakers during the conference. So let's listen now to that panel discussion. So, Matthew Collins, I'd like to welcome you to the ASC Podcast with John Goehle. You did a session here at the New Jersey State Association meeting. So, Matthew, you did a session on what every employer needs to know about the legal risk of at-risk employment. We all know right now that we're facing some pretty serious hiring challenges in the industry. It's universal. It's not just healthcare. It's not just surgery centers, but really all small businesses now are really struggling to hire employees, to find employees. And I'm afraid that some of the challenges that we have now are we bring people on board that might not, they're a warm body and they might not have been fully vetted. So there are going to be situations where we're going to have to discover ways to terminate employees and do it ethically. Your session was on how to reduce those risks. So what was the biggest takeaway that you want our listeners to have from that session?
I think the biggest takeaway is that there's a lot of misconceptions about at-will employment. I have many clients that will come to me after either being sued by an employee for wrongful termination or receiving a demand letter from an attorney, and their response frequently is, well, this was an at-will employee. How can I be sued? And the reality is that at-will employment is really not going to be a defense to almost all of the type of wrongful termination claims that we see. That's because there is a vast amount of state and federal laws that grant various rights to employees and at the same time put many burdens and obligations on the employer. And if the employer is not familiar with those obligations, they could unwittingly terminate somebody who is then going to set them up for a potential claim of, again, wrongful termination, discrimination, retaliation, anything like that. So the key really takeaway for employers is to recognize they never really should be looking to defend an employment action based upon somebody being at will. Really, they need to look at the laws that might be triggered. They need to be familiar with those laws and hopefully take some steps that are proactive to try and reduce the risk of those type of unlawful termination claims.
So, Matthew, it goes without saying that documentation is extremely important. Did you have any advice on how to the best document your thought processes?
Yeah, so documentation, I agree 100%, is very critical. The lack of documentation is going to be seized upon by the employee's attorney. I find that a very easy way to document things these days are through emails. It's a very quick way to either confirm a conversation that you had with somebody, said, hey, we talked about XYZ issues, you're deficient in this area, we need you to improve, or otherwise there's going to have to be some action taken against you. Having formal performance reviews are very good, but you don't really want to wait to document once a year. It really should be an ongoing process that is happening throughout the course of the year and preferably is happening contemporaneously. So if an incident happens, meet with a person and document it fairly quickly. The documentation, the ideal documentation is to document it directly to the employee. If you are not comfortable with that, at least some type of memo to the file also could suffice.
So, John Karwoski, welcome to the podcast.
Yeah. Thank you. Thank you for the invitation.
You did a session on protecting our patients and our employees. So kind of segueing, hopefully a logical segue here is once we got them hired and hopefully we keep them around, how do we protect them and how do we make sure that we're protecting our patients also that have come to our center? So your session was on that topic. What was the biggest takeaway that you want our audience to know?
And John, as you know, education is so important to the staff to understand regulations and regulatory changes, as you do in your daily site visits. I'm doing that with our clinical staff. USP 797 is a concept that I presented this morning. It relates to safe injection practice that is required in every healthcare institution, whether you're making compounded drugs in hospital clean rooms or preparing a syringe in a surgery center. The USP 797 standards will roll out through all of these various activities. And I think really educating staff in technique and the proper handling of sterile injectable drugs was the message today. And knowing what the regulation is and how the regulation will be interpreted. You're very big into your podcast. I listen to your podcast, and the interpretive guidelines of the standards are critical in allowing the staff to know how to perform activities correctly and protect our patients and our fellow employees.
So as a surveyor, I will tell you, USP 797 is is one of those things I keep with me all the time. It's one of the... We have this, I don't know if I call it a joke or a standard phrase. If we're in a surgery center and we're having problems finding something to cite, all I do is follow the anesthesiologist around for a few minutes, and I'm going to find something. And I'm constantly at odds with it, especially those anesthesiologists that are, I'm in trouble here, Monte. Anesthesiologists that work in hospitals that come back and tell me, I don't have to do this in the hospital. First of all, I don't believe them. And then second, I also recognize that, that we have a lot more scrutiny. We have, you have surveyors that are coming out to the surgical unit, obviously, in a surgery center, whereas in the hospital, JCO might not be showing up. So just quick advice on who should you watch? How can we convince them that it's important to do this, and what quick tools might be available for that?
And Monte and I talk quite a bit about this topic in trying to gain the compliance with different specialties. Anesthesia is a practice that's been around ever since surgery started. And I think the changes that have occurred recently, especially with USP 797, have been dramatic in the way they perform their activities. Monte and I are trying to determine how can we get this accomplished by what's in it for them, and not doing it as a disciplinary, penal way of reporting. And I talked about an anesthesiologist this morning that I met with last week at a center that was evident that he would not be complying. He was going to be splitting vials. He had drug shortages, and there was no one going to change them. And after about 10 minutes, we agreed that he will be rounding with me on my next visit, understanding the role that I have as a consultant pharmacist in allowing his patients to have the safest procedure possible. So I think it really needs a lot of hand-holding, and it needs a lot of one-on-ones, and it can't be punitive with a specialty such as, a medical staff profession that, we think is just going to change because it's written in a regulation.
Well said. So, Monte, why don't we segue over to you? You did a session on preoperative screening and testing. I'll tell you, of course, huge changes. Who would have ever anticipated that we needed to do what we're doing today, in addition to making sure the patient is an appropriate candidate for surgery? But it is so important now in today's environment to make sure we're on top of this. So, what advice did you give? What do you think is the big takeaway from your session?
I think moving into the future, we really have to get rid of the old concepts of a shotgun approach that all patients are identical and we need all these labs and, all this information from every patient so that we can determine, it just requires so much filtering, and we get so much really almost useless information regarding how patients are going to move through our system. We have to develop systems within each of our ASCs that are specific to each patient and each procedure. I think classically, we think about anesthesia being the major risk, and they always determine which patients can come through. In a sense, and especially as we move to higher acuity procedures in our ASCs, we really need to stratify the procedure as one of the major determinants of risk of what kind of screening we're going to do on these patients, and emphasize that it's going to be web-based. Patients are going to be able to have to provide information on their own terms, not through phone tag. And then we can process the information based on algorithm and only get what's specific for each patient and each procedure. And that can also be narrowed down to the facility as well. Each facility has different capabilities. I've heard that as a theme today in all the lectures that I heard. And so, all that combined to get specific information to determine if patients could get through our ASCs and have their procedure done safely.
I find preoperative screening to be a big challenge in many of the centers that I visit. Cancellations, last-minute cancellations, understanding the importance of good screening beforehand, especially in those centers. We find a lot in GI centers, for example, very poor upfront screening, which results in cancellations, results in patients that have arrived with already going through a very arduous prep and then find out that they're being canceled because nobody had bothered to do a good screening. What type of tools do you think should be at the top of everybody's list in preparing for that?
Well, I think one of the major things that, and we definitely we wrestle with the same difficulties in the GI centers throughout the Virtua system. It's all about educating the providers, the surgeons, the proceduralists. They're the first line of defense. And I think it's often missed that they need to start that screening process right when they see these patients. And if anyone needs an early intervention, they need to provide that information even earlier than they should. And, I think a lot of times when we go into our centers, we find that patients are screened only the night before. They're getting these phone calls because they've already gotten, especially in the GI world, they already have their instructions to how to do prep, what meds to hold. And the night before, they're getting a call from the ASC. And that is way too late in this process. Right. The screening should really start to occur as soon as a patient is booked. And a lot of times that information is not being transmitted to the ASC. They're not even getting the bookings until the day before. The ASC just have slots. So the more we can push out to the practices to make them understand how essential screening is, that leads to much fewer cancellations. And if the screening process is web-based and patients could do it at their own time and start as soon as they know they're having a procedure, that definitely makes the system a lot more efficient, a lot fewer cancellations, and I think it makes for a much more streamlined process.
So, Cori, there's been a lot of changes as a result of COVID, a lot of I would say opportunities. That's one thing that we've been preaching both in our company and on the podcast is that COVID has, if we play our cards right, has opened up some opportunities that perhaps weren't there before. So, Cori, your session was on service lines made easy. Can you give us an overview of what you talked about and what a big takeaway was from that?
Sure. I co-spoke with Bonnie, so we actually split the presentation and we tried to make it simple for centers to really start looking outside the box about what they're capable of. As you mentioned, COVID kind of brought a lot of opportunities to the surgery centers. And I think what it should show us as administrators and leaders in the surgery centers is that we're really capable of doing a lot of things that we may not have thought we were before. We didn't think we could pivot so quickly and implement some of these changes that were every week or some of them even daily. So taking on a service line now shouldn't be as intimidating as it once was. And we really tried to make it simple for everybody to kind of look outside the box and not be so emotionally attached to a decision. Either definitely this was something that their center should do or definitely not, and really work some steps and analyze whether or not this made sense for their center. Are they going to get paid for it? Do they have the space for it? Do they have a committed champion team to do it? So they have champion physician. Do they have a champion anesthesiologist, OR, and even PACU team? And do they have the space to do it? Some of all this new technology is wonderful, but it takes up a lot of space. And where do we put it? Because none of us built our surgery centers to accommodate all of these things. Most of us probably never dreamed that we'd be doing total joints or even cardiac procedures in an ASC setting. So we didn't design our facilities for that. And most of us are running out of space just with what we have. So how can we think outside the box and how can we really make sure that we're making the right decision?
Yeah, try to fit one of those robots into an existing center with a C-arm and all the other video equipment we have. Trust me, it takes up a lot of space.
Exactly.
So what do you think are some of the biggest opportunities that have, speaking as to, the last year, I mentioned in my session earlier that, total joints have really taken off. And I think I believe it's because people don't really want to, go at a hospital anymore. Patients want to be in our environment. What do you think are going to be what do you think are the areas that they should be focusing on, keeping an eye out for that might have better reimbursement and better opportunities?
I think, as you mentioned, total joints, if you have the capability, especially if you're already doing orthopedics or have a physician that might be interested or links to a physician that might be interested in establishing a program, I think the sooner you get your program established and get your team on board to refine that program, the better. Because I think more and more joints are going to be coming outside of the hospital. And I think you do it now or you can do it later, but do it now when you have the opportunity that you can really build at the pace that you want to. You don't have to, you don't have that high volume necessarily coming right out. You can start with one or two and you can build your programs and refine your program as you go through. I also think looking at some of these cardiac procedures, they're going to be coming more outpatient. But as you mentioned too, more and more patients are going to want to come out of the hospital.
Right.
I think we've been ready for years and we've been trying to tell them that we had lower infection rates, but now they really believe us. I think this time we really got them. And I think our physicians, we tried to always make it easy for them to schedule cases, but now with the backlogs that some of the hospitals have or some of the restrictions that they have, they're really seeing that it could be a great relationship. So these are really the times to think outside the box, like the joints, like GI, like I talked about in my session in multi-specialty. Some of these procedures that we may just think this just doesn't work. It could work. And I think that's where the centers just have to get a little bit creative.
And as you mentioned, the ability to be able to pivot on a dime, that's something that we always joke in our company that whenever a hospital hires us, we double our fee because of all the committee meetings that we have to go to. And then in an ASC, it's so much easier to implement stuff. So definitely, that's I think a hallmark of our industry, and we need to capitalize on that. And to that end, Andrew, you moderated a session on joint ventures and how best to capitalize on that. Talk a little bit about how what your panel discussed and what some of the key takeaways were from that.
Sure. Well, we had a keynote speaker today that talked about his broad experience and long experience in the ASC industry. I'm much, much younger than he is.
Thanks a lot. I'll get even with you.
I know. That said, I've been doing this for 20 years, and I think that my biggest takeaway was when you go back to that time period of 20 years, probably up to about maybe even 10 years ago, the cooperation between the healthcare systems and ASCs was, let's say, frosty, to be polite. Certainly not antagonistic to the point that in some states, particularly CON states where it was outright hostile. But the idea of ASCs and hospitals working together, it was just not a concept that we were familiar with. So fast forward now, we had 3 representatives from 3 different healthcare systems in the state that proved a point that, the joint ventures that hospitals have now entered in with physicians were probably based on economic factors, higher reimbursement rates, for instance. But yet, here in this past year or so, the support that was given to help guide ASCs through this pandemic by providing communication, by providing resources, by providing a lifeline in some cases for helping ASC to keep their employees employed by redeployment was very impressive. And I think proved that at the end of the day, we are all working together and we are all rowing the boat in the same direction.
So what do you think is the future, Andrew, of the hospital ASC relationship? Where do you think we might be heading? I'm having a hard time trying to predict that, and I'm asked that question all the time. So just interested in your perspective on that.
Well, I think we've taught the hospital industry, a few lessons. the very nature, as you mentioned in speaking with Cori, that we can turn on a dime. The structure of our governance, the structure of the very nature of how we operate is predicated on being able to react quickly. We don't have those layers that hospitals do. I think hospitals realize that in order, and I think again, John, you spoke to this. In order to be successful, you can't just plug a hospital-trained person into an ASC. Once that realization, I think, took place, for the healthcare systems, and they seeked out people to manage their joint ventures to prove that there's value to that, I think that those relationships are going to be stronger, and these arrangements, either if you're part of a joint venture, or even if you're outside of a joint venture, I think we'll be working even closer with hospitals to help find the appropriate place of service, for whichever service line that's most beneficial for the best outcome, and that means not only clinically the best outcome, but also financially the best outcome. I think it's going to continue and be even stronger.
So, Claire, it all comes down to quality in the end. I left you for last for a very specific reason. First of all, I'm passionate about it. I know you are too. So all of what we've talked about up until now doesn't mean anything if we can't prove to our patients, if we can't prove to the doctors that we bring, that we recruit, that we can provide good quality care. So the title of yours is, I love it, Embracing Quality Improvement. I talked about it in my session that quality improvement is not paper. I mean, I know that is a perception. It is a culture. So now, you probably had the broadest topic to talk about. Can you just kind of give our audience a bit of an idea of what you focused on in your session?
Well, you're absolutely right, and thanks for your words. So embracing quality, quality is a huge topic and is worthy of, seminars on their own. So I focused on doing an overview of quality improvement, and I guess more of an introduction on quality improvement in the novice track. And I think the biggest takeaway that I wanted people to leave with was to understand that quality improvement is not a punitive issue, but more of an educational approach. And that's been my personal, professional philosophy since I've been a nurse. And in my earlier nursing days, my impressions and experiences with the quality improvement team was that they would come down to our unit and all we'd hear is about what we're doing wrong, we're not doing this right. I said, but all right, so how do we make it better? And we are doing a lot of things right, and that should be recognized. And I would tell my staff, go and hide, I'll deal with them. So as years went on and my experiences became more diverse and always were involved with quality, that was what I took to everybody. This is education. We're going to look at doing it this way because it's better for the patients. It's what the evidence-based science says. It's what everybody says is right for right now. So the primary goal of quality is to evaluate, assess, identify what's being done well, what can be done better, where are there areas for improvement if the standards or the outcomes are not showing that the compliance is being met to where it should be. So those are my basic professional values, as I mentioned before, that I take in all my approaches and promote not only in my company, but with my client ASCs, because it is one that I truly believe in. I believe in that QI should be collaborative. It should be a team approach, not something feared, but something embraced, because the ultimate goal is to improve patient quality of care and improve safety to the patients we take care of. That said, quality is time consuming, and can be very frustrating to a lot of people, and not everybody has the same resources within their facility to be able to devote the time that it does take. So that's one thing that everybody within their facility needs to look at. Where do we build in the time? Who are our resources? Who can we use, whether internally or externally, for a consult? But just know that there are resources out there to help. They are required by regulation and accreditation, but it should be more than just for that. Again, it's embracing it to improve the quality of care we give our patients.
I think when I get a new client, or when I'm working with a client that is just new into the ASC space and trying to understand quality improvement, and especially when I'm talking to nurses who are somewhat new to the process, I emphasize to them that you as a nurse do quality improvement every day. And, you're used to, as a nurse, not getting credit for what you're doing. You find a problem, you fix the problem, and you move on. Quality improvement is sometimes quite simply that. Identifying what it is that you fixed, putting it down on paper, making sure that you broadcast it to everybody possible so that they understand and learn from that experience. We have to learn from our past experiences. We don't want to hide it. And that's why it's so important that it not be a punitive process, that we learn from those things that didn't quite work right. So do you have, some advice as to how to encourage, especially, and when I say younger people, I'm not necessarily meaning always young people, but people that are new to the industry or are coming over from a hospital environment, how they might learn to embrace quality and become advocates instead of just thinking this is something I have to do in order to get the paperwork in line?
Yeah, and those are great points and a great question. I think like any other job that each of us do, any other tasks that nurses learn in nursing school and, learn going into practice as new nurses, switching to different specialties, learning new things. I think quality is the same thing. It comes down to learning about it. Learning is knowledge, and knowledge is power. And once one understands what the quality improvement process is, that whole cycle, and there's resources out there, but once you understand what that process is, it's easier to try to assimilate it into the mechanisms of reporting, the documentation that's required. But you're absolutely right. As nurses, as healthcare providers, and no matter what job anybody's in, we do this every day. And we all go out with the intent of improving what we do, and that's quality. Long ago, when I first established my business, I adopted the process from AAAHC, and I don't mean to be, promoting one agency over another, but their 10-step, their 10-element process is the one that really clearly defines, makes sense, and really have to learn it, understand it, and it's adapted by every accreditation agency and regulatory surveyors. So I think that's probably a start, whether an agency is accredited by Joint Commission, Quad A, AAA, no matter who it is, it's still the same process. And the other part is, I think it's incumbent upon administration, the governing board, to also embrace it and send out culture, that message to everybody in the facility that, again, it's not punitive. This is educational. It relates to patient care. And this is why we ought to embrace it and work together as a team.
Okay. So what I thought I would do now is open up to all the panelists, anybody that wants to chime in. We've had a difficult year. This has been a challenging year. I mean, we say that all the time, but it has also been an opportunity to learn a lot, I think, be it how to make sure that we follow the regulations, how do we pivot with regard to the types of services that we're offering, how we revise our quality improvement programs in order to adapt to the new reality that we have, how we interface with, hospital systems, joint ventures. We're finding, development has suddenly begun again, and that there's a lot of opportunities out there, for new surgery centers or expansions. So I just want to put the question out there, or the question out to everybody here. What is something that you've learned in this last year that you think has been an important part of your development and your organization's development?
I can start that, John.
Sure, Monte. I
think, our ASC staff leadership have really learned how far they could go during this pandemic. I think the easiest thing for everyone to do at the beginning was shut the doors, and then we'll just come out from our hole when this is all over. Yeah. But in fact, what our experience has shown is, thinking forward, being a part of the solution, and trying to understand what our role was during this pandemic. We gained a lot of strength out of that. And I think our ASCs all realized, that they're an essential part of the healthcare system, and they can provide essential care under the most trying circumstances. And staff, it's been said over and over that you can't take a hospital staff member and move them into the ASC. But I think what we learned, interestingly enough, is our ASC staff are so competent that they can pivot on a dime and really become infection control and infectious disease experts in moments, and be able to provide, the highest quality of care to very susceptible patients, and do it in just such a phenomenal fashion. I think we really showed what role we play in the healthcare system, and how far we've come and how far we can go.
I'd like to add a little bit outside of the ASC. I agree with Monte 100%, not number one, but also the importance and relevance of our state and national associations. We always look to them to help us, with regulatory issues, and, with, sometimes, fighting those that we think, are against us for, imposing higher degrees of hurdles or regulations. But in New Jersey, a plug for the ASC Association, we, number one, found that our relationship with the Department of Health really helped give guidance not only to our member centers, but to all ASCs in the state. Our mission, which is to promote outpatient surgery in the state, transcends membership. We helped craft some of the regulations with the department. They looked to us as the subject matter experts, and we're continuing to do so. Daily we help member centers and with questions about interpretation of those regulations. We work with ASCA as well in guidance on determining whether it's guidelines for elective surgery, which we help disseminate from the ASA and American College of Surgeons. All of these resources became vital. I can't stress that word enough, vital for us to maintain operations during this time.
And to add, I think it was really important to learn this year how important it was to make sure we surround ourselves with a good team and really lean on our colleagues. I think this topic in particular, it was evident that it is impossible for one person to know or keep up with everything and changes. And, just having that person or a team of people that you can reach out to and get that information was so important, just to either validate what you were thinking or bring new information to you, and just make sure that everybody stays as current as they can, and that common goal of keeping our patients and our staff as safe as we possibly can.
I think it's been an incredible year. All of us in healthcare, we know how much we have to be adaptable and flexible and think outside of the box, which Cori said so well earlier. I think this has been an even more incredible year for people to adapt, become flexible, find workarounds that enable them to continue to practice making it safe for themselves, making it safe for patients. And it's been quite a challenging year. For me personally, the majority of my work that I do with my client is some on-site work, but predominantly over the internet. So the technology, of course, is a tremendous boon I wouldn't be able to do what I do. But to have thought that one day we'd be having our annual conferences and meetings and doing things like we are now, and seeing how quickly the New Jersey State Association rallied and assembled to get everything online and bring everybody together so that we all were, going out there on our own. I think it was more than incredible. And again, it shows that what we can do to keep moving.
And John, did you have any last minute thoughts there?
Just real quickly, John, just here in the last 20 years, providing medication safety guidance, and the nurses and clinical staff in these facilities are so wonderful. I have a saying, sometimes you just don't know what you don't know. And nurses and doctors, all of them, they'll reach out to me for guidance and my expertise. And I think it's a great team that we build in our ASCs, incorporating all of our specialties for the betterment of the patient.
I want to thank all of the panelists here. This has been a great opportunity. I wish I was together with you in person, so we'd have more time to talk. But thank you for your time and again, your support of the New Jersey Association.
Thank you, John.
Hopefully next year.
Hopefully next year.
Thank you.
Thanks again.
Thanks very much.
Thank you.
Thanks, John.
Bye, everyone.
Care.
We would like to thank our sponsor, Ambulatory Healthcare Strategies, the nation's leading regulatory compliance resource for ambulatory surgery centers. For more information about their services, please visit ah-strategies.com, email them at info@ah-strategies.com, or call John Goehle directly at 585-594-1167. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your comments and questions. Please email us at comments@ascpodcast.com.